Hi all, myself Dr. Arun Kumar K, Consultant Emergency Medicine, Amrita Institute of Medical Sciences. So today I'll be presenting a review video of AHA guidelines, which includes cardiac arrest, post-cardiac arrest resuscitation care, and all the arrhythmias, which includes tachyarrhythmias and bradyarrhythmias. So starting with cardiac arrest algorithm. So this is a cardiac arrest algorithm of 2018 guidelines. So we need to know what exactly the difference between asystole and pulseless electrical activity. So asystole is defined as a complete absence of demonstrable electrical and mechanical cardiac activity, and pulseless electrical activity, or PEA, is defined as any one of the heterogeneous group of organized electrocardiographic rhythms without sufficient mechanical contraction of the heart to produce a palpable pulse or a measurable blood pressure. So by definition, as simple as that, asystole and PEA are non-perfusing rhythms requiring initiation of excellent CPR immediately whether either of them are present. So in the ACLS guidelines, asystole and PEA are addressed together because successful management for both of them depends upon excellent CPR and rapid reversal of underlying causes, especially hypoxia, hyperkalemia, poisoning, and hemorrhage secondary to trauma. So asystole may be the result of a primary or a secondary cardiac conduction abnormality, possibly from end-stage tissue hypoxia and metabolic acidosis, or rarely even the result of excessive vagal stimulation. So it's very crucial to identify and treat all the potential secondary causes of asystole and PEA as rapidly as possible. So as tension pneumothorax and cardiac tamponade makes CPR ineffective, I'm just saying about a scenario, and often rapidly reversible, the clinician should never hesitate to perform immediate needle thoracostomy or pericardiocentesis if thought is required. So after initiating CPR, immediately consider and treat the reversible causes as appropriate and administrate epinephrine. The dose is 1 mg IV every 3 to 5 minutes. I will come to the exact dose in the algorithm when I explain to that. Neither asystole or PEA responds to defibrillation. That's the most important point which we should remember, because still certain physicians still practice defibrillation in terms of PEA or cardiac arrest secondary to asystole. Atropine is no longer recommended for the treatment of asystole or PEA. Cardiac pacing is also ineffective in cardiac arrest and is not recommended by AHA guidelines. So in summary, treatment for asystole and PEA consists of immediate consideration and treatment of reversible causes and excellent CPR with epinephrine administration until either ROSC or a shockable rhythm occurs. So excellent CPR is performed until the rescuer is ready to perform early defibrillation and is continued until adequate spontaneous circulation is achieved. So begin performing excellent chest compression as soon as sudden cardiac arrest has been recognized, and continue while the defibrillator is being attached. So if the defibrillator is not immediately available, so continue CPR until one is obtained. As soon as defibrillator is available, attach it to the patient and charge it while continuing CPR, and then stop compressions to assess the rhythm and defibrillate if appropriate. That means if it is appropriate rhythm is there, that is pulseless VT or VF. If a asystole or pulseless electrical activity is present, continue CPR then. So resume CPR immediately after any shock is given. So I'm just trying to explain the whole algorithm process in an extended way so that you can understand it in a much better fashion. So there are certain points to be remembered. Is decreased time to defibrillation improves the likelihood of successful conversion to a perfusing rhythm and patient survival also. So for the monitored patient who sustains a witnessed VF or a pulseless ventricular tachycardia arrest, if a defibrillator is immediately available and defibrillator pads are in place, immediately charge the defibrillator and deliver a shock. Now what we use now in our hospital setup is a biphasic defibrillator. So biphasic defibrillators are recommended because of their increased efficacy at lower energy levels. So the ACL guidelines recommend that whenever employing a biphasic defibrillator, clinicians use the initial dose of energy recommended by the manufacturer, that is 120 to 200 joules. So if this dose is not known, what can be done? In that scenario, we can use the maximum possible dose which can be used. So we suggest first defibrillation at maximum energy for VF or pulseless VT. ACLS guidelines recommend the resumption of CPR immediately after defibrillation without even checking a pulse. Now this should be very much taken into consideration, because usually what we see in the ward in sort of code blue scenarios and all, once the patient is given a shock, immediately some of the healthcare workers perform a pulse check, which is not supposed to be done, which has not been set by the AHA guidelines also. Clinicians should stop compressions to perform a rhythm check only after 2 minutes of CPR, and therefore not before the defibrillator is fully charged and ready to be discharged if the rhythm is VF or pulseless VT. So if VF or pulseless VT persist at least one attempt at defibrillation and 2 minutes of CPR, administer epinephrine at that point of time, either in view of like either IV or IO access, every 3 minutes while CPR is continued to be performed. Premature treatment with epinephrine, that is within like 2 minutes of defibrillation, has been associated with decreased survival. That's what the AHA guidelines are saying. While it's been under the controversy that whether vasopressin should be used or not, what AHA is saying is, while vasopressin may be used, but then it has been removed temporarily from the treatment algorithm of cardiac arrest, and the trials suggest that it is inferior to epinephrine in terms of cardiac arrest algorithm guidelines. Now, antiarrhythmic drugs may be considered after second unsuccessful defibrillation attempt in anticipation of a third shock. Now, so what's the antiarrhythmic of choice? It is amiodarone. Now, what is the amiodarone dose then? So the amiodarone dose is 300 mg IV or IO bolus with a repeat dose of 150 mg IV as indicated. Or what are the other drugs which can be used? It can be lidocaine. So what's the dose? 1 to 1.5 mg per kg IV bolus. Then 0.5 to 0.75 mg per kg every 5 to 10 minutes. Now, if we are dealing with a polymorphic ventricular tachycardia, the drug of choice is magnesium sulfate. So the dose is 2 grams IV or IO bolus followed by maintenance infusion, which has been considered by the AHA guidelines in terms of torsade de pointes, but it is not otherwise recommended in routine use in adult cardiac patients. So although the ACLS guidelines advocate the appropriate use of advanced airway management and treatment specific medications, these interventions have not at all shown improvement in sudden cardiac death. Therefore, we always have confusion when a patient is unresponsive, when the patient is brought in cardiac arrest. Should we secure the airway or should we start with CPR? So all these guidelines which prove is such intervention need not be initiated at the expense of performing excellent CPR and early defibrillation. So studies have proven repeatedly that interventions like advanced airway or something other than starting CPR has no superior results when compared to starting excellent CPR and early defibrillation. So these are the 2018 update ACLS algorithm. I have shown here the recent guidelines of 2020 guidelines. We will come to the detailed video of in another session. Now there is one more thing which has to be peculiarly mentioned is, now there is an adult cardiac arrest algorithm for suspected or confirmed COVID-19 patients. Now the basic difference between a normal ACLS cardiac arrest algorithm and the COVID-19 cardiac arrest algorithm is, before even starting the CPR, what algorithm says is you have to don your PP properly. You have to don your PP properly, and the number of people which has been acquired as a team to for cardiac arrest should be like limited. So limited personnel, you should don your PP properly and consider resuscitation appropriately. The issue is the main difference between a normal cardiac arrest and the COVID-19 cardiac arrest, you have to prioritize intubation and then resume CPR, because almost what we see in the normal clinical scenario has not been seen in COVID-19 patients, because what's the most common cause of cardiac arrest in COVID-19 is in fact hypoxia. So you have to secure the airway in that case. So what should be done is, one is prioritize intubation, and then you concurrently go with CPR. You should pause chest compressions for intubation. So if intubation is delayed, you should consider going for a supraglottic airway device. Connect to the ventilator with a double filter whenever it's possible. So these are the small changes which has been brought into the COVID-19 case scenarios coming with cardiac arrest. So I have given up the cardiac arrest algorithm for confirmed or suspected COVID-19 patients. So these are some of the guidelines which has to be used. And to tell about CPR quality, I don't think extra mentioning has to be done, even though I'll just put some points onto the CPR quality. One is push hard and push fast. We know that. Push hard means at least 2 inches or 5 centimeters. Push fast means at least 100 to 120 compressions per minute, and allow adequate chest recoil, which is very important. Now, you have to minimize interventions or interruptions in between compressions, and you have to avoid excess ventilation. At the same time, you change compressions every 3 minutes. And if there is no advanced airway, that is, you have to continue CPR, and like at the rate of like 30:2 ratio, the compression ventilation ratio I meant. And what you have to do is you have to use a qualitative waveform capnography. That is, if you want to improve the CPR quality, we can use E/CO2. So if E/CO2 is less than 10 millimeter mercury, you have to increase the CPR quality also, because that is what the latest device is saying, guidelines. And there is something called as intra-arterial pressure monitoring also. If relaxation phase, that's a diastolic phase pressure less than 20 mm mercury, you have to attempt to improve your CPR quality. So these are the two important things which should be considered when giving adequate CPR. And I have talked about the shock energy for defibrillation, and talking about advanced airway. One thing is you have to prioritize intubation, again repeating the same point, repeating the prioritization of intubation in terms of COVID-19 patients. The one thing to be done is you have to minimize closed circuit disconnections, use intubator with highest likelihood of first pass success. You have to consider video laryngoscopy in terms of COVID-19 patients, and endotracheal intubation, or if at all endotracheal intubation has failed, you have to definitely go for a supraglottic advanced airway device. And waveform capnography or capnometry has to be definitely used to confirm and monitor the ET tube placement. So, and once everything is done, you have to give one breath every 6 seconds. That is 10 breaths per minute with continuous chest compressions. Now again, those are things which has to be considered in advanced airway. I have talked about drug therapy, which the drugs which has to be used is, one is epinephrine, which has to be like 1 mg every 3 to 5 minutes, like once 1000 dilution followed by 10 mg IV push of normal saline. And second drug is amiodarone, again 300 mg bolus followed by 150 mg the second dose, and lidocaine, which I have already told. Now we have to say about the reversible causes, that's the H's and T's, everything. So hypovolemia, hypoxia, hydrogen ions or acidosis, hypo or hyperkalemia, and hypothermia, which concludes the entire H's. And T includes tension pneumothorax, tamponade, it could be either a cardiac tamponade, toxins, thrombosis, which can be either pulmonary or cardiac. Right. So talking about the treatable causes which is associated with cardiac arrest, one is acidosis, which can be part of sequel. It could be a part of diabetes, it can be a drug overdose, it can be because of renal dysfunction, sepsis, shock, etc. The second condition which is commonly associated in our part of the world is anemia. It can be because of GI bleeding, it can be because of recent trauma also. Cardiac tamponade, again trauma comes into the picture. Post-cardiac surgery, malignancy, or probably even pericarditis even. Hyperkalemia because of drug overdose, renal dysfunction, hemolysis, excessive potassium intake, rhabdomyolysis, which is one of the most common cause of acute renal failure. Tumor lysis syndrome, which is exclusively found in malignancy sort of people. Hypokalemia, either because of alcohol abuse, diabetes mellitus, even drug overdose, or diuretics, and profound GI losses. Hypothermia because of alcohol intoxication, significant burns, drowning, drug overdose, elderly patients, endocrine diseases, spinal cord disease, etc. Hypovolemia because of burns, diabetes, GI losses, hemorrhage, sepsis, or even trauma. Again, hypoxia, hyperarrhythmic obstruction, hyperventilation. It could be either because of neuromuscular disease or CNS dysfunction, even can be because of pulmonary disease also. Myocardial infarction, that's the most important cause and the most common cause of cardiac arrest. Poisoning, history of alcohol or drug abuse, patient coming with altered mental status, classic toxidromes such like sympathomimetic, psychiatric diseases even. The next cause is pulmonary embolism. It could be, there should be a history of either recent surgical procedure done in terms of orthopedic procedures, peripartum, risk factors for thromboembolic disease, recent trauma, immobilized patient, etc. Tension pneumothorax. Probably you have to ask history about central venous catheter placement, mechanical ventilation, pulmonary diseases like asthma, COPD, and even thoracic trauma also. So these are the most possible treatable conditions which are associated with cardiac arrest. Now this sums up what all should you do when a patient with cardiac arrest comes to the ER. Now we will move on to the next part of the presentation, which is rhythm abnormalities. We start with bradycardia. So for the purpose of ACLS, so for a common man or probably a common doctor, an MBBS doctor, for the purpose of ACLS, ECG interpretation is guided with three major questions. First is the rhythm fast or slow? The second question is the rhythm regular or irregular? And if the QRS complexes are wide or narrow. So these are the three important questions which has to be considered when you talk about rhythm abnormalities confirmed by AHA guidelines. So bradycardia is definitely conservatively managed most of the times. So what is bradycardia then? So any heart rate less than 60 beats per minute is considered to be bradycardiac. But what is symptomatic bradycardia? Symptomatic bradycardia generally have a heart rate less than 50 beats per minute. So the AHA guidelines recommend the clinicians not to intervene unless patient exhibits evidence of inadequate tissue perfusion. So what are the signs of unstable condition like instability or unstable bradycardia? I will talk to that point. So the signs and symptoms which I was talking about inadequate tissue perfusion is one is hypotension, second is altered mental status, third is signs of shock, ongoing ischemic chest pain, and evidence of acute pulmonary in the form of breathlessness. So hypoxemia of respiratory origin is a common cause of bradycardia. So if the perfusion is adequate, determine the oxyhemoglobin saturation in a pulse oximeter, and if the perfusion is inadequate or pulse oximetry is unavailable, assess the patient for signs of respiratory failure, just like increase or decrease respiratory rate, diminished respiratory volume, retraction, or even paradoxical abdominal breathing. So bradycardia in an intubated patient should be always considered to be represented as one is esophageal intubation or tube displacement until proven otherwise. So what do you do for bradycardia then? So we generally administer unstable bradycardia to be managed in a separate way and a normal bradycardia managed in a different way. So we generally administer atropine while simultaneously preparing for prompt temporary cardiac pacing. That is like either transcutaneous pacing or transvenous pacing. Or even we try to start infusion of a chronotropic agent for bradycardia patients with clinically significant symptoms. Now what are the signs or what are the causes of a bradycardia patient with significant symptoms? One is high vagal tone. It could be because of inferior volume myocardial infarction. Second, it could be like medication induced, that is beta blockers, conventional blockers, or digitalis, or even conditions like high degree AV block with narrow QRS complexes. So if the bradycardia is thought to be due to a conduction disturbance at the level of bundle of S or probably below the level of bundle of S, with a wide QRS complex in complete heart block, or Mobitz type 2 second degree AV block, there is no more point giving atropine. So we should avoid atropine and move directly to either cardiac pacing or administration of a chronic tropic agent. So what the ACLS guideline says, in that case, definitely you should go for a expert consultation in transvenous pacing. Before that, what can be done in the ER is, if atropine is ineffective, we can definitely go for a transcutaneous pacing or a dopamine infusion or epinephrine infusion. So this concludes the bradycardia algorithm. One more thing to be told is the atropine doses. The first dose should be given at the level of 0.5 mg, but then most of the Indian hospitals, we have atropine dose which comes in terms of 0.6 mg in 1 ampule, so that is justifiable to give 0.6 mg. So the maximum dose possible which should be given is 3 mg. So this dose has to be repeated every 3 to 5 minutes. And dopamine IV infusion in terms of 2 to 20 microgram per kg per minute in terms of requiring any sort of chronotropic agents, and epinephrine infusion which in terms of 2 to 10 microgram per minute infusion. So this is about bradycardia. Again, the next slide which we are coming to is tachycardia algorithm. So what is tachycardia then? So tachycardia is defined as a heart rate above 100 beats per minute. But to call it as a symptomatic tachycardia, the heart rate mainly involves like more than 150 beats per minute, unless underlying ventricular dysfunction exists. So again, the management of tachyarrhythmia is governed by presence of clinical symptoms and signs caused by rapid heart rate. So first determine if the patient is stable or unstable. Again, how do you find unstable signs? As I described earlier, it could be hypotension, it could be altered mental status, signs of shock, it could be acute heart failure manifested as acute breathlessness, or even it could be ischemic chest pain also. So again, so we have found that, and then we come to the ECG currently. So talking about ECG, we again have 3 questions in our mind. One is if the patient is in a sinus rhythm, if the rhythm is regular or irregular, and third question is the QRS complex wide or narrow. Now, why do you have to consider this? Because we have separate managements, separate drugs for regular narrow complex and wide complex tachyarrhythmias. Now, so what are the causes of regular narrow complex arrhythmia? So 2 most important of them which has to be encountered is, one is sinus tachycardia and the second is supraventricular tachycardia. Now, sinus tachycardia is a common response for most of the conditions like fever, anemia, shock, sepsis, even pain can trigger sinus tachycardia, or even heart failure like pathology also. So what do you do for this? There is no medication is required to treat sinus tachycardia, but you have to treat the underlying cause. Now, talking about supraventricular tachycardia. Now, what is supraventricular tachycardia or SVT? It's a regular tachycardia which is most often caused by a re-entrant mechanism within the conduction system. So the QRS complex is usually narrow but can be longer than 120 milliseconds if a bundle branch block is there. So that is what we call as SVT or supraventricular tachycardia with aberrancy or fixed bundle branch block. So vagal maneuvers which may block the conduction through the AV node and result in interruption of the re-entrant circuit also. So vagal maneuvers alone, just like the Valsalva maneuvers or the carotid massage. So nowadays we have something called as modified carotid massage also, convert up to 25% of SVTs to sinus rhythm. While Valsalva followed immediately by supine repositioning with passive leg raise has shown to be more effective, which is also called as modified Valsalva. So SVT refractory to vagal maneuvers is treated with adenosine. Now we all know adenosine has an extremely short life, which is probably less than 30 seconds, and the dose of adenosine has to be like really specific. So what we use in adult is 6 mg IV push, followed by, first of all, through possibly the largest possible proximal vein, followed by an immediate 20 ml saline push and elevation of the extremity to ensure drug enters the central circulation before it's been metabolized. So this is a dose 6 to 12 mg, 6 mg followed by 12 mg. So if the first dose of adenosine doesn't convert to rhythm, the second dose and the third dose of 12 mg IV can be given. So larger doses has to be given. What we have learned is the larger doses like 18 mg IV can be given in patients requiring, patients needing doses in terms of the patients on treatment with theophylline or theobromine, or who consumes larger dose of coffee. And smaller doses in terms of like 3 mg should be given in patients who take dipyridamole or carbamazepine or those with transplanted heart. The only thing is the low dose should be given only through the central vein. Now, what should be done prior giving injection like adenosine? So prior to injection, while the patient is about to be prepared, so we have to talk to the patient regarding the possible side effects like chest discomfort, dyspnea, flushing, and probably you have to give some more reassurance that these effects are very brief. So perform continuous ECG monitoring during administration. Now if the adenosine fails to convert SVT, so we have to consider other etiologies for this rhythm, which includes either a atrial flutter or probably a non-entrant SVT. So if the conversion attempts fail, we initiate either rate control measures like a non-dihydropyridine calcium channel blocker or beta blocker. We have to consider metoprolol, or it can be considered like a dilsum or diltiazem, or even agents like verapamil also. So this is about regular narrow complex tachycardia. So talking about irregular narrow complex tachycardia, now what are the possible causes are, one is atrial fibrillation, that's the most important and the most common cause. The second cause is atrial flutter with variable atrioventricular node dysfunction, multifocal atrial tachycardia or the MAT rhythm, which is usually considered as a secondary cause to a COPD patient or COPD acute manifestations. Or the next possible rhythm is sinus tachycardia with frequent premature atrial complexes. So how do you manage this case? So the initial goal of treatment in stable patient is control the heart rate. Use again with a diltiazem 15 to 20 mg IV push over a period of 2 minutes, and repeat the dose in a higher way, like around 20 to 25 mg IV to be given after like 5 minutes. So that is about the diltiazem dose. So if you are using verapamil, you can use up to like 2.5 to 5 mg IV over 2 minutes, followed by 5 to 10 mg IV over 15 to 30 minutes. So that is about calcium channel blockers, which is non-dihydropyridine calcium channel blockers. So if you're using a beta blocker in the form of metoprolol, you can use 5 mg IV for 3 doses every 2 to 5 minutes. Now, which has to be remembered while using a calcium channel blocker or a beta blocker is, these both agents can cause or even worsen hypotension. So patient should be closely monitored when the drug is being given, and patient at greater risk of developing severe hypotension, especially in the elderly group of individuals, will require loading doses that are below the usual normal range. So combination therapy with a beta blocker and calcium blocker increases the risk of severe heart block, which has to be monitored and which has to be considered very lethal. Now when you talk about regular wide complex is, so I will come to the about cardioversion and all. So one thing to be told about cardioversion is, cardioversion of a stable patient with irregular narrow complex tachycardia should not be undertaken without considering the risk of an embolic stroke. So if the duration of the AF is known to be less than 48 hours, the risk of emboli is very low, and clinician may consider giving an electrical or a chemical cardioversion. So this has to be this thought process has to be bothered when you treat a patient with this sort of rhythm abnormality. So talking about regular wide complexes, a regular wide complex tachycardia is generally ventricular in origin. So aberrant conducted supraventricular tachycardia may also be seen in the form of a regular wide complex rhythm. But the problem is the differentiation between a VT and SVT of the aberrancy is very difficult. So in that case, you assume that VT is present. So what should be done then? So in case of regular wide complex tachycardia with a monomorphic QRS complex, if you are giving in terms of you have to differentiate between the SVT with aberrancy and VT, adenosine can be used in terms of diagnosing and treatment. So if you should never consider giving adenosine to patients who are unstable or manifest wide complex tachycardia with irregular rhythm or polymorphic QRS complex. So adenosine is unlikely to affect ventricular tachycardia, but is likely to slow it or convert as SVT with aberrancy. I know there is a whole lot of controversy regarding this point. So this is more of a point which has been suggested by the AHA guidelines to come to either diagnosis or treatment of SVT with aberrancy, because what they see, SVT with aberrancy will respond to adenosine than other agents like in fact you can still give amiodarone. What AHA is suggesting is you can go with an adenosine shot to either diagnose SVT with aberrancy and in terms of treatment also. So other antiarrhythmics which are usually being used with stable patients with regular wide complex tachycardia include procainamide, which is the dose is 20 mg per minute IV, and amiodarone, which is like 150 mg IV given over a period of 10 minutes, and you can go with infusion also. So if your hospital is using sotalol, which is a beta blocker, which the dose is 100 mg IV to be given over a period of 5 minutes. So this conclude how to treat the adult tachycardia, whether it is narrow complex or wide complex. So again, coming back to the algorithm, the things to be done is very clearly mentioned in the sort of algorithm, which is first you have to identify and treat the underlying causes, and then you have to maintain the patent airway, you have to keep cardiac monitor continuously, you have to monitor the BP, and you have to give oxygen also. It's exclusively like ABCD algorithm, and then you have to come in terms with whether the patient is having unstable or not, and if it is unstable you have to consider synchronized cardioversion. Now again, synchronized cardioversion, the initial recommended dose which has been mentioned by the AHA is if it is a narrow regular complex it is considered to be 50 to 100 joules, and if it is a narrow irregular it is 120 to 200, either biphasic or monophasic. If it is regular it is 100 joules, and wide irregular it is defibrillation dose to be used. So these are the synchronized cardioversion, the doses of the electrical shock which been used, and then considering about procainamide infusion also, which has been mentioned in the algorithm, and amiodarone dose also, and sotalol dose also. So this concludes the adult tachycardia algorithm. So now we consider the most important thing is, once you have a resuscitated patient, what has to be done next? So 3 things to be maintained and managed in post-restriction care is, one is you optimize the cardiopulmonary function and perfusion of vital organs, and if at all you find out if there is a possibility that patient can have an MI after taking the ECG of a post-cardiac arrest resuscitation patient, then you have to immediately shift to for thrombolysis, or probably go for a PCI in wherever the center we are working with. And then you have to implement strategies mostly to prevent organ system dysfunction and injuries. So the most immediate threat to survival during the first minute to hours is cardiovascular collapse. So intervention to optimize the blood pressure and maintain end organ perfusion has to be triggered, which is like IV bolus of fluids, vasopressors and anotropes, which mainly help in preventing secondary injury from hypotension. So additional short-term goals which has to be considered in the first 6 hours of care include, one is optimizing the oxygenation and ventilation, correcting dyslipidemias. So determination of the etiology of cardiac arrest and initiation of relevant treatments are performed concurrently with a horizontal survey in mind, and resuscitation efforts has to be put forward to prevent recurrent cardiac arrest and optimize the outcome also. So what the normal evidence suggests is the use of therapeutic hypothermia, or TH, or targeted temperature management has been done successfully, and which has showed that studies have proven that it minimizes the brain injury, and targeted body temperature should be achieved within the first few hours following resuscitation. So these are the important thing which has to be considered in terms of post-cardiac resuscitation care. So this is the 2020 guideline which says about the post-cardiac arrest algorithm care. So once the ROC has been obtained, first thing we have to do is you have to manage the airway. So early placement of endotracheal tube or what we call as a crash intubation has to be done, and the respiratory parameters has to be specifically maintained in terms of SpO2 to be maintained between 92 to 98% and PCO2 from 35 to 45 for better neurological outcome. And the BP management, as I told earlier, systolic BP should be more than 90 mm mercury and the mean arterial pressure to be maintained above 65 mm mercury. So once that part is done, you have to immediately obtain a 12 EDC to rule out any sort of STEMI or unstable cardiogenic shock, or probably any sort of mechanical circulatory support to be required or not. And followed by which we have to assess the neurological outcome in terms of if the patient is following commands or not. If the patient is comatose, you have to immediately go for a therapeutic temperature management, and you have to go for an immediate brain CT and other critical care management. And then you have to shift to the ICU immediately, and followed by other management protocols also. So this is a brief management of what you will do in terms of post-resuscitation care. Now, when you talk about ACLS, you have to talk about when you terminate restorative efforts even. So the best predictor of outcome may be the end tidal carbon dioxide level following 20 minutes of resuscitation. So ETCO2 function of carbon dioxide production and its venous return to the right heart and pulmonary circulation. So very low ETCO2, less than 10 mm mercury, followed by prolonged resuscitation more than 20 minutes is a sign of absent circulation and a strong predictor of acute mortality. So that when you terminate restorative efforts, one is the duration of restorative effort more than 30 minutes without even getting a sustained perfusing rhythm, number one. The initial ECG rhythm of asystole, and the third is prolonged interval between estimated time of arrest and initiation of resuscitation, and absent brainstem reflexes initially itself, normothermia, and patient age and severe comorbidity situations of the patient. This slide sums up the criteria for determining the futility of resuscitation followed out of hospital cardiac arrest. One is the arrest which has not been witnessed by a EMS personnel. The second is a non-shockable initial cardiac arrhythmia in the form of either a asystole or a PE, or no ROC has been achieved prior to administration of the third dose of epinephrine. So I am summing up my presentation on ACLS. So the key principle which has to be taken care of in performance of ACLS, one is excellent CPR has to be done. Defibrillation or defibrillation of a pulseless ventricular tachycardia or a VF as rapidly as possible. Rapid identification of reversible causes, and treat cause of non-shockable arrest like PA and asystole. You have to consider the 5H and 5Ts, and if at all any reversible causes have been there, you have to correct rapidly. So this concludes my presentation on AHA guidelines and the recent advances of COVID-19 patient presenting with cardiac arrest. Thank you for your attention.